Welcome everybody to the first global online meet of virtual surgical planning and design of surgical guides group. So in this meet today, right, we have three speakers. I'm very glad to have Sammy all the way from Australia, Sydney, Australia, who'll be talking about comparison between planning result and post-surgery result achieved in orthopedics and maxillofacial. All right. Sammy, are you ready, Sammy?
I'm ready indeed, Roland. Thanks for the nice introduction.
Okay, take it away.
Let me share my screen. Welcome everyone, and thanks for coming to our first VSP meeting. My name is Sammy, and I'm a clinical engineer currently residing in Sydney, Australia. So my main experience lies within orthopedics, specifically in deformity corrections and limb reconstruction. For today's presentation, the title of my presentation is Does it match what we planned? I'm going to start with a short introduction to VSP and its benefits, and then dive into something, in my opinion, is underlooked, which is the difference between the results that we hope to achieve with our planning against what post-surgery results look like. The more we investigate such results, the more we come into an understanding of what we need to develop and change about this technology that will lead us to a better results with time. So if you have any questions, please put them in the chat box or write them down somewhere. And at the end, I'll read your questions and we can open this up for a discussion. So very briefly, I'm sure you all know virtual planning is a technology requested by surgeons a lot nowadays. It involves the use of patient-specific images like CTs and MRIs. We slice them into 3D models and perform a simulation. And the simulation aims to find the best course of action that the patient needs based on their medical condition. So VSP is widely used along many fields, such as orthopedics, maxillofacial, cardiac surgery, and so much more. I've taken up the time to put a list for you on the most common fields that use surgical planning. When I first looked at this list, I realized there's a lot to learn, actually. And I think every professional here would appreciate the importance of grasping the knowledge needed to plan surgery in different fields. So some of you might plan in one or two fields. I personally do orthopedics, and I recently started doing maxillofacial as well, but I definitely would like to add other ones to my skill set. So please let me know in the chat box, how many fields do you do surgery planning in, and what are they exactly? I'm sure you know as well, there are many benefits for surgery planning. Among those are the ability for trial and error. So where we can simulate different outcomes and have a ready plan so we don't have to think much in the operation room. Also, it changed the whole way surgeons look at deformities. The ability to see a deformity in 3D will every time give you a fresh perspective on the case and what the solution should be. It reduced surgery time, it reduced error, it gave us a more controlled and predictable outcome, and also increased the patient's satisfaction. So moving into today's topic, I will be covering those cases shown in front of you, where I discuss the results that were achieved after surgery and compare them to the 3D plan. First, a post-surgery study for 9 patients undergoing forearm corrective osteotomy, including distal radius. And then second, post-surgery comparison of orthognathic planning for 30 patients who had a bimax or a double jaw osteotomies for both maxilla and mandible. Now, the results of this presentation is not going to be surprising, right? This technology has been used for a long time and it's growing. So we can conclude the effectiveness of such solution. But if you're like me, very passionate about VSP and DSP, you would kind of appreciate to see the actual numbers, right? And if part of your role is showing or selling those to your surgeons, then today's presentation is actually very beneficial for you. Starting with upper limb, corrective osteotomies in the upper limb with patient-specific instruments have been widely growing. And if you're working in upper extremities, you might notice the fact that forearm deformities are possibly the most common deformities that we see among the upper limb. I myself have looked at almost 200 orthopedic deformity cases in the last year and a half to 2 years. Most of these, or the big percentage, were forearm deformities. Although the concordance between planning results and post-operative clinical outcome has been rarely investigated, it's very rare. It's very common for surgeons to take post-operative imaging, but I never had a situation where a post-surgery CT has been forwarded to us for assessment. So in this study, we'll look at 9 patients who undergone 12 corrective osteotomies, 2 proximally, 3 mid-shaft, and 4 distal radius. 2 cases were congenital, and the rest were malunions or post-traumatic deformities. All of these were performed by the same surgeons. And as you can see in the table, the age group were between 15 to 64, and the approach was always to correct anatomically according to the contralateral side. Follow-ups were conducted at 10 to 25 months post-surgery, and just to clarify this, the corrections here were done using custom cutting guides and bone models and off-the-shelf standard plates. The first couple of indicators that were looked at are VAS and DASH. VAS is a measurement for pain, which is a survey given to the patients, and DASH is a measure of functionality. How much were the patients able to conduct day-to-day tasks after surgery? Interestingly enough, this table shows a great improvement in both indicators. 6 out of 9 patients were satisfied. The other 3 reported that they were neither satisfied, they're neither happy or unhappy about their results. For those patients with neutral results, I think other elements can play a big role, especially maybe soft tissues. But when we look at the 3D analysis of post-surgery later on, you can see that from a bony correction point of view, planned corrections were achieved with a great accuracy. For patients that reported satisfactory results, you can see those numbers for post-surgery have dropped massively. For example, if you look at the first mid-shaft case, you can see pain score recorded was 4 out of 10. It dropped to 1.7 out of 10 after follow-up. The second mid-shaft case, the pain indicator has dropped from 10 out of 10 to 0.4 out of 10, which is a massive improvement. Same thing for functionality, where you can see a big drop of numbers. For example, in the first case, the survey shows there was a drop from 88 out of 100 to 25, where 100 means complete disability and 1 full functionality. The next 2 indicators we're going to look at are directly related to movements, which are elbow extension and forearm pronation and supination. Testing was done for both of those movements on both the right and the left side in the patient. As I mentioned before, anatomical corrections were the plan, so you hope to achieve results that are similar to that other healthy arm. So looking at the side of surgery and comparing the numbers for each case top to bottom, you can see for elbow movements, range of motion has been restored fully. 5 to 10 degrees of difference may be present, but in our experience, those numbers are negligible. I mean, if you can extend your arms to 130 degrees instead of 140 degrees, those 10 degrees will not make much impact. So for elbow movement, it's basically the ulna or the olecranon rotating around the humerus. So you can see not much impact when the surgery is performed on the distal radius. But for pronation and supination, this movement is very important and we use it on a daily basis. Anything that involves rotating your wrist will basically involve the radius rotating around the ulna. So basically deformity in either bone could impact this movement. Also reading the numbers top to bottom, you can see very slight differences. The results achieved with surgery planning in comparison to the healthy is very close to the healthy contralateral side. The difference as well as maybe 5 to 10 degrees, which is not massive again and shouldn't impact this motion. But before we jump into the 3D models, the next range of motion we're going to look at is the wrist flexion and extension, and radial and ulnar deviation. Again, looking at those numbers, you can very much appreciate this technology. And again, the numbers are impressive. It almost feels like those patients never had a problem in the first place. I mean, you can, even in a healthy patient, you can sometimes see 5 to 10 degrees difference in both arms. Very slight differences, as you can see in the table, but if you ever see those cases go without planning, you know that getting such results are difficult even for your most experienced guys. One of the osteotomies that were performed was on a soccer player who fractured both his radius and ulna. After the accident, he had only the radius plated and the ulna was treated conservatively. So later down the line, the ulna malunited and the surgeon requested 3D analysis and 3D printed guides to correct the ulna. The red is the mirrored contralateral side and the ivory is the deformed ulna. As you can see, the bone models, as you can see in the bone models, the image clearly shows ulnar extension and ulnar supination. This X-ray is for after surgery. You can see from a correction point of view, the ulnar position looks very good. And looking at the bone models on the right, some residual deformity was still present, which is about 4 degrees of supination, and the extension was fully treated. Moving on, we have another comparison in maxillofacial surgery. 30 double jaw osteotomies were performed. A Le Fort one was done on the maxilla, and either a sagittal split or a vertical split of the ramus was done on the mandible. To evaluate the accuracy of virtual surgical planning here, symmetry planes and landmarks on the surface of the skull were defined, as you can see on the slide. Frankfurt horizontal plane marked by number 1 in image A, midfacial plane marked by number 2, and coronal plane marked by number 3. And then we have the points. Number 4 is the midpoint contact between the maxillary center incisors, and the number 5 is the midpoint contact of the mandibular central incisors. Number 6 and 8 are the first maxillary molars, and number 7 and 9 are the first mandibular molars, specifically the anterior cusp. For linear analysis, the distance between the selected landmarks and the symmetry planes was measured, and for both simulated and post-surgery, and the difference was calculated. For angular analysis, the angles between the symmetry plane discussed in the previous slides and those planes shown in this slide were calculated and compared for both simulated correction and post-surgery results. The planes used here are the 3 lower planes shown in the image: palatal plane, occlusal plane, and mandibular plane. So the planes that we discussed before, and these planes, we took the angle between them and we measured it for both post-surgery and simulation, and we compared the results. On the left, you can see the landmarks, and on the right, you can see the difference in distance found between planning results and actual results. For example, from U1, the midpoint between the maxillary incisors, you can see a mean distance of 0.7 mil to Frankfurt horizontal line, 0.4 mil to the midfacial plane, and 0.8 mil to the coronal plane. The biggest difference was in L6, left and right, where the biggest distance we've seen is 1.2 or 1.7 mil. I'd like to hear your opinion at the end on what do you think of those numbers. In Australia, I don't think this type of surgery is performed anymore without planning. I could be wrong, but as far as I know, we have the private health insurance that covers the cost of the guides and the plates, so it's easier to get those planning done for everyone. But I also think the nature of such surgery requires great accuracy, hence why this technology is being used a lot by maxillofacial surgeons. From an angular perspective, this probably reflects on another set of positioning. These angles would be impacted if the bone was moved too much up and down, superior or inferior, and also rotational movements in the coronal and midfacial plane would impact these angles. But as you can see, the numbers are great. Averages between 0.9 to 1.6 mil difference between planning and execution. This is one of the cases included in the study. On the left, you can see the bone models before and after surgery, and on the right, you can see the impact of the correction on the shape of the face. Thank you everyone for listening. This is the end of the presentation. Please let me know if you have any comments or questions.